So we now have a few minutes for a very short question and answer session. So if anybody has raised their hand throughout the meeting so far, if you either want to raise your hand or use the chat function, and we can start some short discussion. Thank you. Angela, I believe you've got your hand raised. So Angela, over to yourself for your question. Thank you.
Thanks, Sarah. It was really just to kind of say thanks, first of all, for the very informative presentations and sharing knowledge and experience across the board. It's been really helpful in kind of setting examples of what could be done in services throughout. I guess it was just for myself to kind of point out, I guess, types of trauma that I think we also need to highlight further in when we're talking about gender-based violence, and that specifically relates to experiences of women from ethnic minority backgrounds, specifically how experiences of racism can also be an adverse childhood experience, also experiences of female genital mutilation, forced marriage, and also if we're talking about kind of alleviating and avoiding the impact of trauma through systemic approaches, then we can't ignore the asylum system and the immigration system and how, you know, processes within those systems actually are extremely traumatic, especially for women who might be seeking asylum because of fleeing war or trying to protect their children from FGM, for example. So it was really just to kind of highlight that and see how we can use this information to further inform our trauma approach.
Yeah, I don't know if any of our speakers want to address that, and then I can move on to another quick question. Anne, and certainly Jen, or even Sheila, Mary, or Caroline, if you want to provide comment on Angela's question.
I'm happy to chip in if it helps. I would say that if we think about the socio-ecological model of health and how that relates to violence against women, it very much has the cultural aspects wrapped around it as core business. So whilst we haven't directed our conversations this morning particularly on that topic, I would hope that you would understand, rest assured, that that is absolutely central to the way we should approach the messages around trauma.
Yep, thank you. Caroline, you've come on screen. I don't know if you want to say anything in relation to that.
No, it was just to completely agree with the question and to agree with what Anne has said as well. You know, kind of in our trauma flower, we're very much thinking about culture and context, and unfortunately we can't have a deep dive about kind of every particular element, but I agree with the philosophy of those are all forms of violence against women in different contexts. So yes, absolutely.
Thank you. I'll just move on very quickly. Julianne Alexander, apologies for putting you into the spotlight, and please feel free to suddenly lose your connection. However, I noticed you sort of raised a very valid point, and it comes back to collaboration. And your question was, if there is limited collaborative practice in your area, where do you start? So I suppose we have, you know, 4 experts or 5 experts, sorry, that have all brought different agencies together, all with their own differing agendas and priorities to really deliver key sort of work. So Julie, if you don't want to speak or you don't want to add anything further, I'll just go straight to our speakers to see what their thoughts on that are. So limited collaborative practice in an area, where do you start?
I'll come in if you like, Sarah. I would say, I think a really good place to start would be any partnerships that you're perhaps on. So I know that having this dialogue through groups such as the Violence Against Women Partnership, or asking to go and speak to the Child Protection Committee or go and speak to the Adult Protection Committee, or indeed the third sector equivalents of those, the family partnership or community planning partnership, to give us talk, to have that dialogue within those settings. may be a good place to start.
Excellent. Mary, you've come on screen as well, and I appreciate that you've probably done quite a lot of work in pulling people together to get that drive and synergy amongst the groups over in Fife. I don't know if you have anything to comment on that, and then I'll turn lastly to Caroline.
Yeah, I think I'd just, very much mirror what Jen was saying. The partnership for us, Fife's always had a really strong partnership. But, as an individual agency, we just put ourselves out there. We asked to go and meet people. We asked to go to the team meetings at the psychology department. And I think we got to know people beyond, or we tried to get to know people beyond them as someone who's just a referrer. So we tried to kind of understand their position, which at times was quite different to ours, and their way of working. So, rather than getting irritated by someone's lack of understanding or appreciation of what we did, we kind of tried to, understand that they had their frame of reference and we had ours, and saw past that and just kept working together, just kept trying to, meet people and welcome people. Lots of people come to our team meetings to find out what we do. And I think the relationships are just at the core of it all. And I think that just mirrors what we do in the, in therapy rooms and in support sessions. It's about the relationship that you can build between people that makes all the difference. So get yourself out there. It's not easy, and especially now, but, make contacts.
Ideal. And Anne, I'll move to you, and then I'll go to Caroline to have the final word on this.
It's very possibly what Caroline's going to say. I was just going to highlight, Caroline, you might want to tell them about the trauma-informed practice links in the health boards.
That wasn't what I was actually going to say, but it's probably a good idea for me to say that. And what I was going to do was come to something that you'd said. And I think I completely agree with the implementation process, how do you practically do that? But there's the other part of that, which is Anne talked about, the complex and interacting needs of people affected by complex trauma, whether that's domestic abuse or not. And what we're finding, for example, when I work with forensic medical examiners, is that somebody who's coming into forensic medical examination system, they don't really know or care whether it's a police person or a forensic medical examiner or a member of rape crisis that's in front of them. That we design systems as kind of individual organizations, but the people that we see, the people that need us, are actually usually, if they've experienced complex trauma, have got complex and interacting needs, and we need to think about ourselves as a system. And part of that is what's come through for me from the presentations that we've heard so far, is the value of interactive collaborating systems. That sometimes that reticence to collaborate can be around, oh, this is an extra thing for my plate. I don't want to collaborate with these people because it's an extra thing. But as soon as organizations and systems see it's not an extra thing, it is the thing, and actually it makes lives easier across the board rather than more difficult, then people come on board pretty quickly. So I agree with what everybody has said in terms of making sure you're interacting with networks and just getting out there in relationships and understanding different people's perspectives. But also, as you start to collaborate, it gets a hell of a lot easier as everybody is able to support each other and sees that actually as a network they're stronger than each of the individuals. What Anne was prompting me to do there was also to say that as part of the National Trauma Training Programme, we do have this great title, TBTIC, so Transforming Psychological Trauma Implementation Coordinators, and some of you will get a chance to meet some of them. They're fantastic. We've got one in each of the different health boards, but they've got a remit to support the programme of the National Trauma Training Programme in each of the different areas across third sector and health, etc. So it's just to highlight that they exist, and they're doing fantastic local work where you are, and you'll meet some of them in the group discussions later on.
Excellent. Julianne, you've come on screen. You're no longer shy, so hopefully that has been able to answer your question. Have you got anything else you want to add? Oh, I think you're on mute still.
Yeah, that was really helpful. Thank you. I actually have found it more challenging coming back into the NHS. I used to be part of third sector for a long time, and having come back into the NHS, I think you don't always have access to the same partnerships that you used to be part of, or it's at a different level, and it can be quite complicated to actually find the right people to connect with to be able to build these collaborative working, networks. but that was very helpful. Thank you.
No, that's perfect. And I see everybody has suddenly lost their shyness and is putting their hands up. So apologies. I am sticking to a very tight schedule. And I know that obviously details for people will be shared. I think you'll have got details of our keynote speakers. So I'm sure, and I'm sorry to volunteer for this, if anybody has got any questions to direct to our sort of experts on screen, then I'm sure they'll be delighted to field any questions or can provide any assistance moving forward.